Good morning. My name is Anthony Maritato. I'm a licensed physical therapist who specializes in treating individuals after a total knee replacement. So this morning, I'm going to be sharing a presentation going through the Brigham and Women's Hospital total joint replacement post-surgical protocol. I'm going to break this video up into 3 sections. The first section is going to be day 0 to 3. I'm going to review the protocol with you, share my screen so that we can look at the same document and you can get a general idea of what to expect following your total knee replacement. Now, while this protocol might not be exactly what your surgeon uses, you can get some general idea, and there's going to be a lot of common language and common things that we talk about. So let me start by sharing my screen and let's go through it. You can see here, this is a total knee arthroplasty protocol. Arthroplasty is the same as replacement. I'm going to scroll down. There's some great information in here about pain management, but let's jump to phase 1, immediate post-surgical phase, day 0 to 3. So a couple of things that you'll notice. They talk about the patient goals. The patient will perform bed mobility and transfers with the least amount of assistance while maintaining appropriate weight-bearing precautions. Now, most patients after a total knee replacement will not have weight-bearing restrictions, which means you can put your full body weight through the lower extremity that has the replacement. But occasionally there are times where maybe a complication happened or there's a pre-existing condition and the patient's not allowed to put full weight through the surgical leg. But for most cases, full weight bearing as indicated is what's recommended. Bed mobility includes stuff like rolling, scooting, sliding, positioning in bed. The most common position is going to be recommended with the leg elevated and the knee straight, but your surgeon is going to give you specific guidance and your physical therapist will help you better understand what bed mobility is. Transfers is your ability to go from sitting at the edge of the bed to laying in bed to getting out of bed. Transfers could also include stuff like toileting, so getting on and off the commode, transfer in and out of the car, or just transferring from one position to another. Ambulate with assistive device for between 25 and 100 feet. Now, most patients in the US will be provided with a forward wheel walker. That is the standard metal frame walker that has the wheels in the front and the slides on the back. It provides you with adequate stability and some mobility. In European countries, oftentimes they're prescribed crutches, but here in the US, it's almost always a forward wheel walker. Occasionally, patients will go from the walker to a cane to no assisted device, but everybody's going to be a little bit different. The goal is to regain at least 80 degrees of passive and active range of motion in the knee. Now, 80 degrees is going to be referring to the amount of bend, the amount of flexion. They're going to try to get you as close to full extension, which we'll see here in a minute, but 80 degrees of knee bending. I'm going to tell you, depending on how well they're managing the post-surgical pain, how well your swelling is doing, other factors are going to come into play. I've seen patients 48 hours after surgery that can't get past 60 degrees of flexion. It's very normal that in the first 24 hours, you might have 80 or 90 degrees of flexion, but then you might actually lose some flexion around days 3 to 5. And then that flexion will return somewhere around days 7 to 10. This is common because of responses to pain, responses to swelling, and just the overall experience of having this surgical procedure. You can see number 4, gain knee extension that's equal to negative 10 degrees. So 0 would be considered full knee extension. Negative 10 means that you're lacking 10 degrees of extension. So there's a little bit of a flex to the knee. But the goal is always to try and get to full knee extension, 0 degrees, as quickly as possible. Flexion, the initial goal is typically 80 to 90 degrees as quickly as possible. Number 5, independently perform operative extremity straight leg raise. So a lot of patients will have difficulty flexing the hip, lifting the leg on the surgical side. Part of it could be attributed to tourniquet use if your surgeon is using a tourniquet. Part of it could be attributed to increased swelling, increased pain. This is most commonly recognized when somebody's sitting in a chair and they're trying to lift the surgical leg so the foot comes off the ground. Maybe they're trying to get in and out of a car and they're trying to lift that leg into the car, or maybe they're at the edge of their bed and they're trying to lift that leg into their bed. I typically see when patients have problems with hip flexion or a leg raise, there are strategies we can use to improve it, but typically it's going to be like that for 10 to 14 days. You still want to practice. You want to get your therapist working on activating that quadricep muscle and the other hip flexors. But it is common to have difficulty lifting the surgical leg. Where are we? Number 6, verbalize an understanding of postoperative activity recommendations and precautions, including use of proper positioning for the lower extremity, range of motion exercises, and strengthening exercises. So probably one of the most common things is a patient will have a knee replacement. They'll get discharged, they'll get home, and then, of course, like anything, we forget everything we were just told. We're medicated, we're groggy, we're not sure what they actually said. So it's important to have somebody that you trust, hopefully a family member or a close friend, who can be a second set of eyes and ears for you, who can listen to the post-surgical discharge instructions, who can understand what they're telling you should be done. And then when you get home, can help you with that. Now, there are physical and occupational therapists who will provide what's called mobile therapy. It's therapy in the home. This could be done on an outpatient basis, and they can help you make sure your home is set up, make sure you're positioning correctly, make sure you understand everything that you should be doing during the first week to 2 weeks after surgery, because that's usually the most complicated time and it's the most frustrating time. You're not sleeping well. Some patients have a hard time managing the pain and maybe need to change their pain medication. So having somebody on your side is really important. Number 7, patients will also be educated on superficial massage of the knee joint to minimize hypersensitivity following surgery. Now, if you've seen any of my other videos, I have another YouTube channel. It's the Total Therapy Solutions, Total Knee Replacement channel. I do a lot of education on self-massage using a rolling pin or different kind of tools. But I find that during the first 5 to 10 days, really focusing on managing the swelling, reducing the pain, desensitizing the tissue, improving fluid exchange is going to lay the groundwork for a better recovery. Because being fearful of too much swelling, too much pain is always a setback and makes things more difficult. So you can talk to any physical therapist about that. They'll have strategies to show you on how to do this. Looking forward, some patients will receive a CPM, a continuous passive range of motion. However, most won't. It is a covered benefit under Medicare Part B, but most of the time, there is no medical indication for CPM. Most patients will not use a CPM, but if you believe that there are potential complications or reasons why you would benefit from a CPM, I would talk to your surgeon about that before surgery, just to get a sense for what their rationale is to either prescribe or not prescribe that for you. Now, if we go down, we can see here, let's skip the rehab services, therapeutic exercise, and functional mobility. So what are the things that you're going to be doing during that day 0 to day 3? Active, active assisted, and passive range of motion. These are going to be your classic heel slides, muscle activation, just tightening, squeezing the muscles, relaxing the muscles. Patellofemoral and tibial femoral joint mobilization. This is going to be done by the therapist. It's a very gentle range of motion activity. It should not increase pain or swelling or have any negative side effect for you. Soft tissue massage. You'll have strategies to do it yourself using a rolling pin, or your therapist will do it for you. Isometric exercises for the quads, hamstrings, glutes. This is basically when you squeeze the muscle, activate the muscle without moving the joint. Straight leg raise, we already discussed. Lower extremity range of motion. So working on your elevation to reduce swelling, working on your extension and your flexion. We talk about closed chain exercises. So this is going to be basically exercises where your foot is in contact with the floor. When you're sitting and you stand, that is a version of a closed chain exercise. When your feet are on the ground and you're pushing or pulling, that is a version of a closed chain exercise. So if you think of the joints in your lower extremity, like your hip, your knee, your ankle, they form a chain, a kinetic chain. When you close the chain, it's because your foot is in contact with something that kind of closes that circuit. Then we talk about gait training on flat surfaces and on stairs. Gait training is walking, walking on a flat surface, walking on stairs. These are things that we want you working on during that first 0 to 3 days of recovery. And then, of course, transfers. I already mentioned in and out of bed, in and out of a car, on and off the commode. Those are important transfers that need to be practiced, and you need to feel confident. Even if they're difficult, you at least need to feel confident that you know what to do and how to do them. Modalities. So the most common modality, cryotherapy, you see there, 72 hours, that's just icing the knee. Applying cold to the surface of the skin to reduce pain and sensitivity. Now, there are patients that I work with that do not respond well to the sensation of cold. They prefer heat. You can talk to your surgical team. Some surgeons will allow you to use either moist heat or dry heat. It really just depends on the philosophy of the therapist and what they believe is best for you. But understand that these are solely modalities to reduce pain. They don't facilitate healing. They don't change anything in the tissue quality. It's just to reduce pain. And then, of course, patients are encouraged to use cryotherapy or ice 20 minutes before and after their exercise programs. They'll also give you information about medication before and after your exercise programs. A couple quick precautions. So if you have any reason to limit weight bearing, you want to monitor those weight bearing restrictions or precautions. Weight bearing as tolerated, WBAT, just means that you can put as much weight through the extremity that was operated on as you're comfortable with. I'm a physical therapist. My primary focus is on building your confidence, making sure that you feel good putting all of your body weight through the surgical knee. And if you don't feel good yet, we want to do things that get you comfortable with it because it should not increase your pain. It might be make you anxious, make you nervous because you're not sure if the knee can handle your body weight. But that is where the physical therapy comes in to build that confidence so you know what you can do and what you maybe aren't ready to do just yet. We always want to monitor the wound healing. We want to make sure that we consult with a physician if we see anything that doesn't line up with expected normal healing. So, for example, I recently had a referral. It was 48 hours after surgery. The patient presented. I saw a little dot of blood on the outside of the dressing, but once we started to get under the superficial layer, we realized that there was a significant amount of excessive bleeding, and we had to send that patient back to the surgical team to have the wound, the dressing re-administered and addressed because it was just bleeding more than it should be. You're not expected to know the difference between normal post-surgical bleeding and excessive post-surgical bleeding, but your therapist will. Excessive drainage, bleeding, any bad odors or smells coming from the incision. These are all signs that we need to have a medical professional assess what's going on. We want to make sure that we're watching out for any possible blood clots or any excessive swelling. There are things your physical therapist will do to monitor this. We want to make sure there's no exercises with weights or resistance during those first couple days. When you're just getting up and going to the bathroom, when you're doing your ankle pumps or heel slides, that's really enough. The tissue has gone through so much trauma during the surgery that there's no real benefit to adding external resistance. Your body weight is more than enough resistance than your knee is going to need or tolerate during those first couple days of recovery. And then, of course, we want to avoid torquing or twisting the knee in certain ways. A lot of times, I have patients that find themselves in compromising situations where their foot might be wedged into something and they turn their body and they create a painful experience. We want to avoid that as much as possible. The most common areas that something like that happens is getting in and out of the car, because most patients don't have the range of motion to do it properly. Or if they're wearing shoes or footwear that have high friction and grip and they're on a thick carpet, they might put the foot down and twist, which creates torque. We want to control or minimize the effects of that as much as possible. Positioning, they're always going to recommend positioning in a situation where if you're sitting or lying down, we want the knee in extension as much as possible, just because extension is so important to normal ambulation into the future. Oftentimes, they'll talk about placing a towel roll under the ankle so that the knee can hang into extension. But I'm going to tell you that if you're getting good extension, if you're at negative 10 degrees or less, then you don't have to worry about it quite as much. As long as you're working on improving extension, improving flexion, when it's time to rest, it's okay to find a comfortable position, especially if you're dealing with increased pain and soreness. Nothing should be placed behind the knee. Once again, that is simply because they don't want patients developing a contraction, a flexion contracture. So they want to try to keep that knee straight. But if you have full flexion and full extension within the expected norms, I wouldn't worry too much about pushing the range of motion more than you can tolerate. The last section here is criteria for progression. So everybody is going to progress differently. Every person is going to experience a different recovery time frame, but some general guidelines. So the ability to demonstrate good quadricep, that's your thigh, contraction is important for straight leg raise. A straight leg raise is important before you progress to phase 2 of the recovery program. Having active range of motion of between negative 10 degrees to 80 degrees is an important element during these first couple days of recovery. Minimal pain and inflammation. I would say the biggest indicator of good range of motion is good pain control. And I know a lot of patients are really struggling because they're trying to manage, they don't want to be dependent on the pain medication, but they don't always appropriately use the pain medication to achieve the goal of pain control. Talk to your surgical team. You need to have trust in your surgeon and your surgical team in that either they are prescribing the best medication for you, and if it's not achieving the goal, then you need to talk to them to try a different kind of medication. I see a lot of patients who just have poor pain control initially, but they tweak the medication, either a different kind of med or different dosing, and they do amazing. As soon as they get that pain under control to a reasonable level, they build confidence, they gain range of motion, everything else becomes easier. And then finally, we want you to be as close to independent with transfers and ambulation in the home as possible. So being able to go from the couch to the kitchen, kitchen to the bathroom, bathroom to the bedroom, all of those are important. And I can tell you that if you're consuming enough fluids, particularly water, you're going to be getting up to go to the bathroom 2 or 3 times. Well, I'm going to say once or twice every hour or two. So you're going to get plenty of opportunity to practice ambulation and transfers simply because you're going to be going to the bathroom so frequently. So that's the end of phase number 1. I know I went through it quick. My goal wasn't to necessarily dive into any specific details in depth, but it was more to just give you an overview of what you can expect. In the next video, we'll go into phase 2.